Let's talk now about primary immune deficiency syndromes. These are ones that you're born with. The one that involves B cells, you think of X-linked agammaglobulinemia of Bruton type. And this is obviously going to not allow the ability of the development of mature B cells, plasma cells, and the various isotypes that can be of antibodies produced by the subtypes, and leading to agammaglobulinemia. And the mutation involves the Bruton tyrosine kinase. And the clinical findings, obviously, it's excellent. It's going to be on the X chromosome. Since males only have one X chromosome, they tend to be affected, and you get recurrent infections. Why at 6 months, as you recall? Because of maternal immunity or passive immunity is now going to be lost and now dependent upon the endogenous immune system of the infant. And basically what's going to happen is you're going to increase the likelihood of upper and lower respiratory tract infections because of bacterial infections, since we need antibodies to opsonize bacteria. So you can get pharyngitis, otitis media, bronchitis, as well as pneumonia. And common organisms associated with this is H. influenza, Streptococcus pneumococcus, as well as Staphylococcus aureus. Another B cell condition is called common variable immunodeficiency. This is a group of disorders that can affect either the T4 helper cells that help modulate B cell maturation, as well as B cells themselves, and can lead to a hypoagammaglobulinemia as well. And the clinical findings, both sexes could be affected, early onset, obviously childhood, and recurrent bacterial infections, and they also have increased susceptibility to Giardia lamblia, which would typically a GI type of problem that one would see. Enteritis. Complications. It also increases the frequency of autoimmune disease occurring in these individuals that have common variable immunodeficiency. And because there is proliferation of lymphocytes, it can also increase the risk for non-Hodgkin's lymphoma as well as gastric cancer. DeGeorge's is a T cell issue where you have, as you recall, embryologic failure to develop in the third and fourth pharyngeal pouches. And what is important developmentally that form in these areas is the thymus and the parathyroid glands. The clinical findings, obviously, because you don't have parathyroid hormone production, you're going to lead to hypocalcemia or tetany clinically. Then the T cell deficiency, and remember what type of organisms tend to be used by T cells to terms of dealing with them are going to be fungal and viral infections. Typically what one sees, like in AIDS patients, where you're destroying T cells. Then what happens, what's a condition where you involve both T and B cells? What do we call this? Severe combined immunodeficiency. And so this is a deficiency of cell-mediated as well as humoral immunity, and it's going to be due to a defect in the stem cell. There's different modes of inheritance. It could be X-linked mutation of a chemokine receptor. These are important for chemokines. Remember, we talk about these small polypeptides that help recruit cells in an inflammatory process, as well as for different cells to interact, as well as viruses. Remember, AIDS virus requires a chemokine receptor besides CD4 helper cell receptor in order to get entry into CD4 positive cells. Then the autosomal recessive that you've learned about involves adenosine deaminase. Remember, adenosine deaminase is important for deaminating adenosine to become inosine that enters the salvage pathway. So now if you have this deficiency, the adenosine will accumulate as well as adenine and then cause cytotoxic effect on the lymphoid stem cell, then leading to affecting both T and B cell lineages. So the clinical features, obviously recurrent infections with all types of infectious microbes and susceptibility to Candida, CMV, pneumocystis carinii. Remember, pneumocystis carinii can be found in any severely immunocompromised state. We used to see it in AIDS patients because of the development of prophylaxis and early intervention and treatment of AIDS patients. You see this pneumocystis carinii pneumonia less frequently, except on exams like the USMLE. But you can also see other severe immunocombined states like somebody with renal transplantation or people who are getting chemotherapy or induction therapy for leukemia. And then what do you not want to give these patients is a live attenuated vaccine immunization like oral polio vaccination, and they can develop polio because they're not able to modulate this. Another example of both T and B cell dysfunction is Westcott-Aldrich syndrome. The genetics involve the X-linked recessive inheritance, and its mutation gene is a protein. And basically, you have your clinical triad of recurrent infections, both fungal, viral, and bacterial. You're going to have also severe thrombocytopenia leading to a hemostasis problem, and you get a chronic spongiform dermatitis, which means what? Edematous or edema. Eczema is a very common example of a chronic spongiform dermatitis, and the treatment is bone marrow transplantation typically. And the complications, because of the proliferation of lymphoid cells, can lead to non-Hodgkin's lymphoma. And death is usually associated with infection and or hemorrhage because of the thrombocytopenia that's fairly severe in these patients. So when we think of primary immune deficiency, another important area that's critical to the immune system is complement disorders. They both can affect both the classic and alternative pathways. You're going to have C3 deficiency, and that obviously can have recurrent bacterial infections and also increase the likelihood of immunocomplex disease. Then factors C5, 6, 7, and 8 can be associated with recurrent meningococcal and gonococcal infections. Factors in the classic pathway only, the C1q, R, S, and C2 and 4 deficiency cause marked increase in immunocomplex diseases because of dysregulation. And then factors of the alternative pathway, factor B and propyridine deficiency cause increased neisseria infections, and deficiency in complement regulatory proteins like C1, I, and H deficiency or hereditary angioedema. Especially the edema will occur at mucosal surfaces. And there is a corresponding C2 and C4 levels are low in these patients. Here is a diagram to show primary immune deficiency syndromes, just to give you an overview that we've just covered. Here you can see at the top involving B cells, adenosine deaminase deficiency, in both the T and B cells. And then you can see we get X-linked agammaglobulinemia involving the BTK gene, where you can't form the various mature isotypes of B cells. And then DeGeorge syndrome, where you're going to lead to decreased differentiation of the various subpopulation of T cells. And there's also the cytokine receptor for the X-linked form of severe combined immunodeficiency.